I really am very excited to be among clinicians who are here delivering a tremendous task in the trenches. So we'll be making an effort to help you go through a journey which really is not only about patients. How many of you came here because they had difficult patients and that's why they are here? I'm going to give very brief, quick pointers about this whole course, and then we'll have Diane go over some of the expectations from this course. So the pointers are, we really want to have you have some tools with you when you're finishing up with this course. This will be a lot more didactic and experiential. The next segment is going to be a lot more practical, where you will go back to your own facilities and practice what you have learned here. You will be given the assignments to do about a program that you may have developed or you may have wanted to develop, and you would also need to bring in a case study that you may have done, and we'll give you more information how to do that kind of phenomenon. So the intent is going to be, after this course, we want to give you a period of time to practice it in your real lives, and then come back and discuss with us the program that you may have done differently, the cases that you may have done differently, or the cases that you are not finding any success with. Okay? So it'll be a very practically driven insight now, and then we will discuss the cases when you come back the next time. There will be few things that you will hear over and over again, because we have divided it in a manner where different trainers will pick up on those themes. So I will really quickly flirt through them without depth. And the concept is that you're going to have some real underlying reasons why you're here for. We're not going to be very fluffy and just having fun. We are going to be learning skills and tools that you can be able to use, but this is going to require work, unfortunately. We'll be going over a consultation agreements and then going over what that really means in people's lives and your practices. And it takes time to practice each one of those. We will continue to work with some of these consultation agreements, and as I said, that our trainers will kind of go over those in a bit. And we'll talk about the concept of what's a wise mind and what are the practices of wise mind. And simple things will bring in joy to your ammunition of helping others. Very, very simple things. And you say, my God, I had these things all the way, they were all already there. It's almost like when you're driving to your work, how often do you observe your surroundings? You say, I want to be there 5 minutes earlier today. My God, as always, I'm late. And then, so in our rush to cure our patients, we are not being observant of a lot of simple things that can be done in a beautiful manner. I'm going to brag about me for a moment, if you allow me to. Is it okay? Okay. Well, I have about 5 different certifications in various fields of psychiatry. Okay. General adult psychiatry, geriatric psychiatry, addiction psychiatry, forensic psychiatry, quality review, so all these jargons of various things, because I wanted to prove to myself I can earn certificates. I did. Okay. Now I'm in a unit where I have some very difficult patients, and the nursing staff come around and say, well, give him some medications, or the person is not doing well, what should we do? And I'm supposed to be the most experienced pharmacotherapist on the unit. Right, Jack? Okay. So Jack wants me to fix people that I cannot fix. With those 5 certifications behind me and all the knowledge, and I go for my trainings every year to enhance my knowledge of medications. and what medications can do. But there comes a time the medications really cannot do what my nursing staff is asking me to deliver. I just cannot do that. I cannot do that. So they get frustrated and they say, you just don't care for us anymore if we get hurt. Right, Jack? Well, I heard you I heard you say that to somebody else, though. But the point is, our Prozacs of the world and the Zyprexa of the world and all the medicines that I know of have limitations in bringing about the healing and effectiveness in people's life. That's my point. So that's where this little thingy becomes very important, that you know these tools which can be equally, if not more effective in people's life. And these are skills, these are not pills. Okay? So if you leave here without skills, there'll be a shame. I would like you to learn these skills so that you can be more effective clinicians. And then, so all I'm saying is, medications, limitations, we have become a very medication-oriented society, unfortunately. People want a pill. I need a prescription. Why don't you not give me a prescription? So, well, I cannot give you something that's not going to cure you. My pill is ill-suited to your needs. Okay? I have one person on my unit now. She is drowning with pills. She has all the pills in the world that I can give her, and the other doctors can give her. She's sleeping and she's still not doing well. I sat down with her yesterday and I said, the pills are not the answer for you, young lady. The skills are the answer. We got to work with those skills, because otherwise we are going to both fail. So this is going to give you new tools to practice, and it's proven by research, and I'll talk about that later. And so it's not my home-cooked phenomenon that nationally has not been tested. I shut up at this moment. Diane is going to take over and talk about some of the other venues of what we need to be doing next.
Morning, again. Okay. My name's Diane Danish. I am a registered nurse and a licensed counselor, essentially in private practice right now, and also teaching at the University of Pittsburgh School of Nursing. I'm very delighted to be here. I really enjoy teaching, and I also like teaching about subjects that excite me. And I have to say, over the course of the last, I don't know, probably 7 or 8 years since I've learned DBT, I have absolutely found it essentially helpful for every single patient that I encounter, whether they have borderline personality disorder or not, whether they're a difficult patient or not. You can always pull something out of this philosophy or out of the skills to help people. So I use it in my conceptualization of patients. I use it very concretely with patients in terms of, hey, you know what, I have this handout. Let's talk about some way you might better manage that. And they're thrilled to have something concrete. Maybe they're just an outpatient with a lot of depression or a little bit of depression, but they love having a tool. So not only that, but I've also found it to be essentially helpful for myself. Over the last 7 or so years since I've learned it, my life has changed. And you know, I remember when I took the trainings initially, I did not do the intensive training that Lynn and Dr. Chaudhry have had. I did a briefer training myself, but I remember thinking, you know, judgment? Who has judgment? I'm not judgmental. Why would they think that about me? And even just that statement is very judgmental. So my awareness level has, you know, grown in terms of my own limitations and my own ability to be less judgmental with myself and clients. And that's a beautiful thing. Opening your mind and being more flexible can never be a negative. Okay, so let's start with some slides. I got blessed with trying to help you understand what dialectical behavioral therapy means. I don't think I volunteered for that section, but I ended up with it. I find it quite challenging to articulate. I don't find it challenging to understand. It's a rather abstract concept, and I wouldn't expect that you would understand all of it today, but by the time we're done at the end of the full course, you will have an understanding, and various times throughout that of what the dialectical approach and philosophy is. I'm going to take a stab at it now and help you kind of get an introduction in your mind as to what that might be. So let's just start with a couple of statistics. We know that dialectical behavioral therapy is, of course, the treatment of choice for patients that have borderline personality disorder. Again, our focus isn't necessarily just on those patients, but because they tend to be some of the more difficult clients, we will be talking somewhat about that as well. So it is the most common personality disorder in inpatient and outpatient settings. Sometimes they haven't even, sometimes you know a patient who has borderline personality disorder. It's very easy. Sometimes you don't know, and you're treating someone and they have a different approach or they have a different presentation, and you might not even know that. But it is very common. 1 in 4 psychiatric inpatients meet borderline personality disorder criteria, and it occurs in 15 to 25%, up to 25% of all patients. When we're treating difficult patients, how do we respond? How do you respond to patients? What do you do when they're just giving you a hard time? And or what do other people do? We'll talk about other people. What do other people do? We all do it. It's okay. Withdraw. I mean, withdrawal is one of the most common ways. Like, we want to avoid, right? We want to, like, oh, there she is. Like, let's run. Or I'm not doing that admission. Or we're not taking her on this unit. Or whatnot. So that is one very common response to difficult patients. Absolutely. What do other people? The other one is be very reactive, right? Judgmental. Very much the case. But as you can see, neither one of those responses is at all helpful. Not even just for the patient, but also for ourselves as caregivers. We're not feeling very effective. Okay, so DBT blends a matter-of-fact, somewhat irreverent, and at times outrageous attitude about current and previous dysfunctional behaviors with therapist warmth, flexibility, responsiveness to the client, and strategic self-disclosure. Important keywords here are, well, essentially the message is we're viewing the patient's problems as a problem to be solved. We're not judging them. We're not saying we're the expert and you're not. We're not in a hierarchical model. Okay, we're in a very collaborative model with DBT, working with patients to figure out how can we solve this problem. We don't know all the answers, but let's talk about it and let's figure it out. So we reframe dysfunctional behavior as part of the client's learned problem-solving repertoire. Again, some of the typical reactions are when someone does something outrageous, perhaps parasuicidal behavior. Do you know what that means? A lot of self-injury or chronic suicidality. What do we want to do? And a lot of the time we want to, if we're not in an inpatient setting, send them there, right? Get them in the hospital. That's one of the typical overreactions to these patients. Not that you should not consider whether there's a safety concern, but we're trying to, what we know about challenging patients, and especially those with borderline personality disorder, is that they often have chronic suicidality and chronic self-injury. And it often the case is not that they're necessarily going to kill themselves. We need to help them feel more regulated and grounded and then look at a way to solve this problem. So here's the fun part. I'm going to read this because I could not even think about memorizing it. It does get better. This is the hardest slide. Dialectics, a method of argument or exposition that systematically weighs contradictory facts or ideas with a view to the resolution of their real or apparent contradictions. Don't even try to understand that one. Secondly, the contradiction between two conflicting forces viewed as the determining factor in their continuing interaction. That's how I felt after reading those two definitions. Certainly, what does that mean? That's a whole lot of words, right? So again, the process of change through the conflict of opposing forces whereby a given contradiction is characterized by a primary and secondary aspect, the secondary succumbing to the primary, which is then transformed into an aspect of a new contradiction. Don't get hung up on that once again. I actually put these in here because when I give you like my kind of definition, it sounds really good. So it makes me look good. Okay, here, this is better. And I didn't make this up really. The art or practice of arriving at the truth by exchange of logical arguments. Okay, and I will continue to explain that. The process of arriving at the truth by stating a thesis. We all know what that is, I think. developing a contradictory antithesis, the opposite, and combining and resolving them into a coherent synthesis. How can we come together and understand each opposing view, the dialectical parts of the poles, one and the other? How can we come to some understanding together of what this might mean? So not necessarily one or the other. This says not only is it greener over here, it tastes better too. So not one or the other. And not necessarily feeling stuck. You take all the time you need, Larry. This certainly is a big decision. Not stuck. But instead of looking at the confusion on the two bottom signs, looking at it in a different manner. Okay? The top sign, there's the dialectic of those two opposing signs on the bottom. So it's really a new way of looking at something in a different fashion than we're used to. Okay. Dialectics stress the fundamental interrelatedness of reality. And in DBT, we understand that the analysis of individual parts have limited value. And what we're looking at is the immediate and larger context of behavior. So in this instance, instead of these little tiny individual dots that make up a picture, this is all stipple art. You know, stipple art is just little dots. It makes up a much broader picture. So we're looking at the big picture. We're not always looking at, oh my goodness, this person cut themselves, they're going to kill themselves. We're certainly keeping that in our mind. But we're looking at what's the function of this behavior? What does this mean? What do they need? What kind of problem? What is a trigger? Thinking about the larger system of that. Reality is not seen as static, but comprised of internal opposing forces, out of whose synthesis evolves a new set of opposing forces. The video will, again, recap some of the ideas of dialectic. But the idea really is you've got polarities, different views, different ideas, different sides of something, and coming together in the middle. So dichotomous or rigid thinking, or emotions, or behaviors, extreme, what are some examples of that? Got to keep you awake. What are some examples of rigid, dichotomous, right, wrong, that kind of a thing? If I don't get an A, I failed, like an all or none, right, kind of a thinking. What else? What about emotions? Think about patients that we treat that are challenging. Does this make sense in terms of emotions? How so? Right, needing to learn to regulate their emotions, very good. So they might either avoid their feelings, right, or they're very intense feelings, one side or the other. So helping them, and this is one of the skill modules, regulate their emotion is very key. And how about behaviors for these folks who are challenging for us to treat? What are some examples of that? Cutting. So extreme, either, you know, withdrawing and hiding in bed, or maybe parasuicidal or suicidal behavior. So let's talk about dialectic and some examples of that, some types of dialectic that we talk about in DBT. The first one is essential for patients. The first dialectic, and when we say dialectic, we mean there are two, again, opposing forces, and we're coming to a synthesis of them. The need to accept for the client and for us to accept clients as they are, while also accepting the need for change. So most of the therapies that we've learned in school or whatnot, or trainings, are very focused on change, right? I mean, I know that's where I've been in life with as a counselor and a nurse. You know, we want to help people. We want their lives to be enriched, and we want them to enjoy that. But we're often very, very focused on just the change element, not the acceptance. And what you'll find when Dr. Chaudhry speaks about the biosocial theory of patients with borderline personality disorder, and when you see the video, is that this is one of the problems with difficult clients, is that they've had much of a lack of validation in their life. Validation meaning, I'm okay. Okay, so maybe in their lifetime as a child they've gotten a lot of messages that say you're not okay. Or maybe they've been in so many group homes or whatnot that they feel they're not okay. But the reality is they are okay, just as they are. We ask that they keep their minds open for change at the same time. You are okay, and let's help you think about a way to improve where you are, to kind of get some things in life in order so that you can enjoy that. Another dialectic, clients getting what they need and also losing what they need in order to become more competent. So what would they be getting? What? Skills. What would they be losing? What do they need to lose?
Secondary attention from family.
Yes.
Secondary gains.
Secondary gains. So there, but it's that, you know, when you see the video, Marcia talks about the purpose of these behaviors, and they do work. They're effective. Unfortunately, they have long-term negative consequences, but secondary gains, absolutely. They're losing a way to cope initially. They're losing whatever function that behavior provided. They're losing a sense of security at some level. And so we need to help them get what they need while and also lose what they need. Another dialectic, maintaining personal integrity and validating their own views of difficulties versus learning new skills that will help them emerge from suffering. Essentially what this means is, as patients become aware that they have some control over their environment and their emotions and so forth, they often then feel like, oh my gosh, maybe it is me. Okay, and part of it is what their response. The dialectic is sometimes they then feel badly because maybe their perceptions of what's been happening and what's caused their problem, it needs to be modified a little in their mind. And so the dialectic is maintaining their integrity while also learning new skills to help them emerge from suffering. So the fundamental nature of reality is change and process rather than content or structure. The goal really in DBT with patients and ourselves is to, on the bottom bullet, increase comfort with change. More flexible mindset, that's the goal. Okay? Open-minded to problem solving. And this is a simplified version of what a dialectic is. Okay? I like little illustrations. I tend to be a visual person. This worked for me. So you've got a thesis or an idea. You've got an antithesis or the opposite. But when you come back to the thesis, you make a synthesis. Okay? That's the integrated part. These are some concepts we will talk about in more detail in future sessions, but they're very crucial to the basic philosophy of DBT. Willingness versus willfulness, which is, you know, being willing to do something, and the old word for willfulness is stubbornness. We're all familiar with that word. We don't really use that word in DBT because it's judgmental. Willful is a little less judgmental. It really isn't judgmental. It's reality. Patients respond in that way. Needs and wants are dialectic. Sometimes patients have needs to feel safe, secure, and cope, and they also have wants. Well, they have needs to get better and wants to stay the same. That's true, because it's comfortable. Pain versus comfort and security again. There's a dialectic between a therapist and a client. Okay, we're two different kind of ends of the spectrum. And power struggles can happen, certainly. So we need to, this is what we'll be teaching you as we go on, how to avoid that with patients. And validation is really the key, and we'll talk more about that. And this little caterpillar says, but I don't want to change. Change is hard. We all know that, right? If you will, for a moment, just to keep you awake, fold your hands naturally. And which thumb is on top? Notice that. Now I want you to fold your hands with the opposite thumb on top. I don't even think I can do it. How does that feel? Really awkward. I mean, for me, it's like I want to immediately change back to the natural position, right? This is such a tiny little exercise. So think about major life change for these folks. You know, a little tiny thing like that feels awkward. I mean, we have the power to really just move it back. But for a lot of patients, there's a lot. When you make a change, they will be transforming lots of parts of their life. So it's hard. We need to be patient with the process. Okay, just a few more. Dialectics, good and bad guy. This is like the other dialectic. Sometimes as therapists we're the good guy or woman, and sometimes we're the bad guy or woman. Okay, it's one of the dialectics, and even when you learn more about the structure of DBT, you'll understand that we'll talk about skills training group, and there can be a dialectic between the group leader and co-leader. Okay, two different people in the group, between the skills trainer and an individual therapist, and its most in its purest form, DBT involves a skills training group weekly and an individual therapy session weekly. So you've got two different people running those. So there's another potential dialectic even in the professional realm with a patient in the middle sometimes. The dialectic, what we need to do then is certainly validate the client's view. Sometimes they will kind of try to pit one against the other or whatnot. We need to validate their experience, and we'll talk more about validation today. and avoid splitting. Most of us know what that means, which is pitting one against the other. But allowing them to have an opinion and allowing them to have an observation is quite appropriate and actually encouraged. So the other dialectic, what do we focus on? Content or process? Content being exactly what's said and done. Process is what's underlying that. Okay? And you could talk about that in therapy sessions, in group, skills training. And the other dialectic would be following rules versus reinforcing assertiveness. This says, everybody put their fossils on teacher's table. As usual, Sydney was the class creep. There's a judgment. But he put the big, skull on it. So what do we want to do? Encourage? We want to encourage assertiveness and individuality, or do we want to have patients follow rules? And that's our dialectic, right? And that's patients' dialectic too. I've got to be right. I've got to follow the rules. I've got to do it right. But we are also encouraging, hey, some individuality, some exploration with skills and learning how to stand up for oneself and one's opinion. A little confusing slide, just some terms in terms of dialectical communication, what that means, and we'll be talking about we'll be talking about all of these at some point. But change, we've talked about communication, acceptance, it being very reciprocal, irreverent. We'll touch more on that as time goes on. Problem solving and validation. There's your dialectic there. Consultation to the patient and consultation among ourselves, and environmental interventions, as well as case management. So these are really important, the DBT assumptions. This is where you get down to the philosophy of treatment and what it means. And this is not rocket science, but can be very different than what we've been doing. And not that we've been malintended. We're all, I'm sure, here and in this profession because we're well-intended. The reality is sometimes we don't even know we're doing things that might be harmful for patients. So never assuming we're doing it in a malicious way. But number one, clients are doing the best they can. Okay, getting rid of that judgment. No judgment. I rarely think, I don't think people come in and they do the best they can with what they have. That's the reality. If they're stuck, it's because they're scared. They're still doing the best they can. Okay? They might get stuck. And they might be willful. They're still doing the best they can. Really important underlying philosophy of treatment. Clients do want to improve. In DBT, we believe that. They do want to get better. Yes, there are secondary gains to a lot of their behaviors, but they do want to get better. 3, clients need to do better, try harder, and be more motivated to change. Well, the reality here is patients need us to help motivate them and need some skills, but they do need to do some work. It's not an easy kind of, osmosis kind of thing. Clients have not caused all of their difficulties. True. And at the same time have to solve them anyway. Okay, so yes, these patients that we see that are challenging certainly often have a long history, right, of very extensive, horrific stories we've heard. And we believe that's affected them, and that's important to validate that with patients. That is hard. You've been through a lot. And now you're an adult. Let's help you make a decision. Let's help you gain some skills to move to have a life worth living. We do believe that clients, number 5, lives are unbearable as they are currently being lived. We know they're suffering, and this is true. That they must learn new behaviors in all relevant contexts, so not just in session or skills training or therapy, but outside of that in their community or in whatever other element they're in at that point. Clients can't fail in their therapy. That's a new concept, isn't it? Can't really fail. The reality is, if they're not progressing, then we need to figure out why. It's a problem to be solved. Is it the right kind of treatment for them? The most effective kind of treatment? Maybe, maybe not. Are we missing something as therapists? We are fallible. Okay? We might be missing something. That's absolutely possible. Are we doing something? Are we enabling the patient? We need to look at all these things. So we don't believe clients fail. We might move them on to a different treatment if it's not effective, but that doesn't mean they've failed it. It means it's ineffective for them. And let's try something new to help you. Our goal is to help you get well. And that staff providing treatment, this is really important, and we will highlight this throughout. They need support to work with this population, okay? And support doesn't just mean, yeah, we know it's hard, It means coming together as a team and really supporting each other. And we'll talk more about that in future sessions. But a real basic element of DBT is doing that. Okay, so we do structured treatment. We don't always have the same goal, right? This one says fix your marriage, and the guy's reading fix your car. We don't always have the same goal as the person we're treating, perhaps, or in relationship with. But we arrange target treatments in a hierarchy in DBT. We're focusing on various things first. The first one is life-threatening behaviors. Okay, so this is always first and foremost. If a patient comes in and has had an episode of self-injury or starts making statements that indicate that they have some suicidal thoughts or whatnot, and then they go on to talk about their job, we have to back up for a minute. I want to talk with you more about that statement. That concerns me that you said, you know, something about wanting to kill yourself. Let's talk more about that. Or you said you self-injured. I see that here on your diary card, which we'll talk about, which is a way for them to list things that have happened in the past week. You know, we need to back up. Let's back up a little bit. Always, always, always safety first. Anything. So under this category would be suicidality, of course. Self-injury would fit under here most of the time. Essentially what I'm trying to demonstrate is if you can't let go of something that's hindering you, you can't reach out for something new. Okay? And I do that demonstration with patients and they get it. Like, you know, so for instance, self-injury is very effective. Do we think that skills training initially is going to be as effective as cutting or suicidality or an eating disorder or drinking? It's not as effective. A substance or some physiological way of regulating oneself really is more effective for these folks. The problem is, over the long run, it's got negative side effects. So this is always going to be much more comfortable for patients than this. So we've got to get rid of this because that's always going to be the default. Okay, so if you've got a drink and you've got a skill and drinking's been their MO, they're going to drink. I mean, this is essentially easy to figure out. Drink's much more easier. I'm just going to take a drink. So we need to ask them and contract with them to give up those problem behaviors, to reach out for new skills. And the last one is, thanks, quality of life interfering behaviors. Again, sometimes patients will come in and want to talk about their job or their relationships, and which are all essential elements, I mean, for folks like this. But we really have to be sure that before we're talking about quality of life, that they are safe and that they're coming to treatment and they're not doing anything that's interfering with that. Those are priority 1 and 2. This comes third. If those are managed, patients are coming, they're willing, they're, you know, all those things, and they're safe, then this is a great place to go with patients. But not before then. Okay. And this is the DBT House of Treatment. It looks a little complex. What I like about this, however, is I like to show this to patients because it kind of puts in perspective the hierarchy of treatment. Again, people are often unwilling to give up their problem behavior. They're very attached to it. If you see on the first level, stage 1, the problem is severe behavioral discontrol, which would be chronic suicidality. It could be, again, self-injury, using substances, participating in eating disordered behaviors, violence and aggression, withdrawal, and that kind of thing. That's the severe behavior discontrol. The goal is, on the right side, behavior control. That's what we're trying to get at. If you see the fire on the bottom, that's fire. We're in crisis. This is crisis stage, and this is often where we end up with these patients, right? So the goal to get out of stage 1 is getting in control, and that requires commitment and skills. And then you can go to stage 2, quiet desperation, getting in touch with emotions. Stage 3, problems in living and getting a life. And then capacity for sustained joy, number 4. This isn't meant to help patients feel hopeless. It's going to take so long to get there. No, it's really helped to for me, it helps me to demonstrate to patients, this is where we're starting and this is why. This is your foundation. If we don't manage these behaviors well, no matter what you do in the other, you're not going to be able to sustain it. It's going to crumble and fall down.
This is how I was trained as well. You know, when I had the time in the therapy, I want to get down to the bottom of the thing.
Mm-hmm.
And here, on the other hand, she's cutting and doing all the other, taking overdose issues. And, well, this is a shift in that thinking that you don't really get down to the root today. Today is trying to keep the basement safe. Because if she's cutting and taking overdose dosages, bringing about that trauma issues is going to make it even worse.
Yeah.
Okay? So it's almost like if you're running a marathon and you're in the last, stretch of your marathon, and that's what I want to tell you, well, could you do another marathon right now? You would say, are you crazy? I'm fatigued, tired, exhausted, and I just want some break. So these patients at this point in time, at least for me as a clinician, was a turning point.
Yeah.
I'm saying, I need to get them comfortable first. I need to give them a little water, a little mindfulness, a little small comforting ground. And then when the basement is secure, now they may be able to walk now. And which is a very different shift in at least all the therapies and the things that I have learned over my life. Because I all want to get on the problem. It's like if I have a pneumonia, I want to treat your infection. I want to cure you right now. And that's where the problems start, because people cannot take the emotional overload, which is already there, and you stir up the wounds a lot more, and you are having cuts and fillings. And I just want to emphasize that.
Thank you. That's a really good point. And by the way, if you're feeling like judgmental about that, that's okay. Because when I first learned DBT, I was upset about that I couldn't, delve in and help people explore the meaning of their misery. And I thought, oh, DBT is just a Band-Aid approach. All you do is put a Band-Aid on it. I mean, I remember thinking all these things as I was going through the training and implementing that. You know what, we never talk about the deeper issues with these patients. Yeah, the reality is, then I saw this illustration. You do, but you don't in stage 1. You do in stage 2 and 3 and so forth. But in stage 1, you don't, because it doesn't make any sense. It's going to perpetuate the self-abuse cycle. But, don't feel bad if you're having judgments about that. Only with experience will you come to learn. It's a very effective tool, a very effective philosophy of treatment. So that's a very good point. Okay, so that says problem solving on the right and validation on the left. That's the basic core strategy. We'll talk more about validation in coming sessions, as well as later this morning a little bit in terms of this biosocial theory. And there are some examples of validating statements. And versus but. And is a great statement to make. When you say but, everything that follows that, everything that comes before that is negated. So and is a great word to learn to use from this session on over and over. And is a fabulous word. Yes, I understand. It seems you feel it is hard. You are trying. And I'm amazed at how well this works, not only with patients that are difficult, but in my own life. And with various people even that I treat that I don't use DBT, just the skill of validation. I had a patient in my office yesterday who essentially is in her 30s and feeling very confined and pressured by her parents. She's still kind of in that childlike role and feels very obligated to gain their approval, et cetera, et cetera. And what do you think she does when they say, oh, you're just a terrible parent? No, I'm not. I don't do that. I go out with my friends, but it's only 3, on and on and on. And I said, she said, oh, they said, your aunt never went out and she was a single mother. And so then she'd go to try to explain it. And I said, well, why don't you just say, you're right, she never did. Okay, respond to the content of the statement instead of arguing. I said, has that arguing been effective for you? Have you changed your mind? No. Okay, then let's shift gears. Agree with something that they say and take the wind out of their sails, hopefully. Okay? We'll talk more about that as time goes on. Non-judgment is a very key element to DBT, and this is probably the most fabulous thing I've learned, which is how to, not that I'm free of judgments. No one is in this whole world. Every day I catch myself. But I'm more aware of it, and I do, over time, that has reduced for me. I remember one day thinking, I'm going to just go the whole day and not say anything unless it's not a judgment statement. Man, that was a very quiet day. I'm not kidding. I mean, just think about driving down the road. Oh, what are they pulling over there for? Why are they going so fast? On, look what she's wearing. Why, oh my goodness gracious. That's all I did, driving being one. But regardless, it's constant in our minds. But being aware of that is the first step in reducing that.